Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to Breast Intentions. Today, we're joined by Dr. Lisa Hinzmann, a board-certified OBGYN and reproductive medicine specialist here in Cayman at the Cayman Fertility Clinic. With years of experience helping women navigate fertility and hormones, Dr. Hinzmann brings incredible insight into what fertility treatments look like for women in midlife and how this journey impacts both body and mind. Let's get started.
So on today's episode, we have Dr. Lisa from the Cayman Fertility Clinic. Welcome to the show.
Thanks for having me.
Thanks for coming.
Thank you.
And today we're going to talk about reproductive medicine, and particularly reproductive medicine in women in midlife.
Yeah.
So somewhere around the age of 38 to 50.
Yeah.
And just a little bit around like the hormone side. We just have questions.
Yeah.
We have a big interest around this as well, because it's something that we haven't talked about yet.
Yeah.
So why don't you give our listeners a little bit of an introduction of where you're from, what you do, how you got here?
Yeah. So, my name is Dr. Lisa Hinzmann. I'm originally from Germany, moved here 1.5 years ago. I did my residency, so where you specialized in obstetrics and gynecology in Cologne, back in Germany, worked at the University Hospital. After my residency, I subspecialized in reproductive medicine. And I love it. Here in Cayman, I work at the Cayman Fertility Center, but also at Doctor's Hospital, because reproductive medicine is that's my passion, but I still love to do some obstetrics, some regular gynae stuff.
Okay. And you've worked extensively in reproductive medicine and also in perimenopause and menopause health.
Yeah.
What inspired you to bring these two specialities into your work?
I think it went a little different. It's more like you do the specialization in obstetrics and gynecology, and somehow this is such a huge, big field where you can choose, okay, I'm going to focus just on obstetrics, or I'm going to focus on general gynecology, or reproductive medicine. And first of all, what I like about this whole field is that, for example, if you go into the obstetrics route, pregnant women are not sick. To be pregnant is not a disease. And that is one of the things why I love my specialty forever, is that's one thing in medicine where you at some point not always have patients. You have women being pregnant. That being said, I also like the following their journey sometimes of having maybe difficulties to conceive, and then seeing them first thing trying to figure out, okay, what's the reason, then having the possibility to actually do something to help them. And then in the best, when they get pregnant, to stay with them throughout the pregnancy, maybe do the delivery, and then later in life, be their gynecologist for when it comes to perimenopause or menopause. I mean, where I come from in Germany, we have our gynae that we go to on a regular basis, in the best once a year, maybe even more if it's needed. I like to have that lifespan connection with patients.
Right, and following them throughout their whole journey.
Yeah, exactly.
So that's what has inspired you to bring these two into your work. So it is following a woman really through many different stages of her life. So probably the general one would be following a person when they're in their 20s or early 30s through their pregnancy, and then seeing them afterwards, maybe through the perimenopause shifts, and then seeing them into their 40s and their 50s into menopause. Yeah. But then you also may find that you meet people who are looking to get pregnant in their 40s.
Yes, exactly.
Right. And that you may not even have seen them before or know their history. And what are some big misconceptions that you see for women in their 40s and 50s when it comes to fertility?
One of the biggest misconceptions is that it's impossible.
Yeah.
It's not. But it's not as easy as it was maybe in your 20s or early 30s. That's the thing that you have to know upfront before you go into that journey of, trying to conceive. And that's what I counsel my patients, my couples in, and say, like, look, that's what we're working with. That's what you have to be prepared for. And that what can happen, worst way or best way, so that they are just prepared. Because one important thing for me is that I bring them more knowledge and more education so that they are empowered afterwards and say, like, look, I went to see Dr. Lisa, and I went to see if I can still get pregnant and what are my options. And afterwards, that even helps with when you maybe find closure in some topics of your life.
Yeah.
So, yeah.
Right. Okay.
And so especially like my little sister. I mean, she's turning 20. I was 18 when she was born, and like, you can do the math, but my mom was not 18 when she was born.
Yeah.
So I just have it in the family that definitely in your 40s, you can still get pregnant and can get kids.
Yeah. So you're bringing hope to a lot of women. So what does fertility look like for women in midlife, and how is it biologically different compared to women in their 20s and 30s?
Yeah. So the biological clock is real. Like, we can't ignore that. So what we see is that we have two major factors that might have an effect on getting pregnant. That's one, that your ovarian reserve declines, meaning how likely it is that your ovaries are still responsive to your hormones to get to an ovulation, to get even to the point where you could conceive. And also egg quality plays a major role. So egg quality diminishes rapidly after 38, but then especially after 40, 42, there we just see nature does its work. And so these are the two things that make it more difficult and that bring us to the point where I have to counsel my patients to alternatives. For example, not doing the IVF route or trying the IVF route, but being prepared of it might not work. So that's one of the other misconceptions, that even when you're younger, that you go into IVF and say, like, okay, that's going to work out 100%. No, it does not. There is more to it. Yeah.
What's egg quality? What does that mean?
So, men, again, a little bit better situated here. They can produce new sperm. So they can actually do something by changing their lifestyle to improve their sperm quality.
Okay.
We women, we are just born with a certain amount of eggs.
Yeah.
And our eggs are our age. So a 43-year-old woman has a 43-year-old egg.
Yeah.
And therefore, as we know, from our skin, from overall health, that life has an effect on egg quality. So specifically when it comes to chromosome abnormalities that then can be found in our eggs, or that make it a higher risk that even if we would be able to create embryos with IVF, we know that being over 40, over 67% of the embryos that we create in the lab are not genetically normal, meaning they, for example, have trisomia, monosomia, meaning just a different number of chromosomes that would be considered a normal, healthy embryo.
Okay.
So, that is the effect of egg quality. And even having a healthy life and trying to cut out on like drinking, and smoking, and it won't change much in terms of that you can just take a pill or do a therapy and you get your eggs being the quality.
Make your eggs better.
Okay. I mean, we know that there is some supplements that might be beneficial before going into the IVF route in a later age, meaning like end of 30s, beginning of 40s, that I recommend my patients to take upfront. But I always counsel them and say, like, look, it's not going to make them like 18 again.
Yeah.
Yeah.
Okay.
So what are all of the fertility treatments that you do? I'm not really familiar with.
I don't either.
I know IVF.
Yeah.
I think I've heard of something called IUI.
Yeah.
And
So
that's about it.
yeah. I mean, so first of all, before really talking about the IVF treatments, I think it's important to know that the most important thing in the beginning is to do a proper assessment and to do a proper, proper investigations, meaning do some blood tests, do some ultrasound scans, really see what are we dealing with here, and educate your patient like this is what we're dealing with. So that is the first thing that we always do, because that gives me already so much more information to really tell them like, okay, that is what we can work with. Because, for example, what you said, before then considering IVF, there is possibilities of timed intercourse, meaning we do the cycle monitoring. We track the cycle by doing some blood tests, doing some ultrasounds, and just seeing like, okay, when are you ovulating? Are you even ovulating? Do you think you're ovulating, but you're not really ovulating?
Right.
You might have a regular cycle, but that does not guarantee you that there is a proper egg ovulating to be fertilized. So cycle monitoring is one of the steps that we can do before. Obviously, you should not waste too much time on like treatments that don't really have high success rates when you come to a certain age. But another thing is intrauterine insemination. But IUI.
Oh, okay.
So intrauterine insemination is a possibility and an option for couples where we might have a male factor. So the sperm is not the best, but the woman is still quite young, speaking in fertile years here. But there she needs to have proper fallopian tubes, the connection between the uterus and the ovaries, because if the tubes are blocked, because she had an infection before or whatever reason might cause that, IUI is not the option for that couple. And then it is IVF, in vitro fertilization, where it really is about, getting a lot of eggs out of your body and fertilizing them outside of your body in the lab, seeing how they develop into nice embryos in the embryo culture over 3 to 5 days, and then putting them back into your uterus. And then we can store remaining embryos, like we freeze them.
Oh, can you?
Yes. And we can freeze them and they can stay in the freezer for years.
No way.
Yeah. So that is why I think one other thing is really important is to know about options like egg freezing.
Yes.
Because talking about egg quality and our diminished ovarian reserve, the younger you are, the better those two things will be. And so you can at least maybe consider freezing your eggs for later in life, and those eggs stay the age and the quality that you did the procedure, and they don't get older.
Right.
Yeah.
So those are the treatments.
Yeah.
Now, if you're working with someone who is in between 40 and 50,
Yeah.
are any of those off the table?
I wouldn't say off the table, but the chances that they lead to success, meaning we say success is being pregnant and having a healthy child back home, then wasting time on timed intercourse or intrauterine insemination is not what I would recommend, right?
That's what I was going to say, because I'm guessing that people that are in that age bracket, they're like,
There's
in a hurry here.
Yeah, there's a little bit like I try to tell them like, look, I wouldn't say urgency, but you should at least know what you're working with. So meaning you are already in an age group where we know lower ovarian reserve, meaning even if we push you with a high dose of hormones and stimulate your ovaries, we will not get the same amount of eggs out of your body, out of your ovaries, because of your declined ovarian reserve. And then we also have the egg quality problem that not every egg that we get out will be fertilized, will be developing into a nice looking embryo, or even, and that's what the majority of my patients here in Cayman do, is when we then do additional testing on embryos that we created, which is called PGTA, pre-implantation genetic testing for aneuploidy, so that we just get the words right here, is that we then want to find out the embryos, are they normal? Are they with their normal chromosome numbers? And we have to be prepared that being over 40, 67% are not euploid embryos. So what is important to me is that my patients then know, okay, if we go that route, the worst case could be we are getting there that we have embryos and we get them tested and we get the results back. None of our embryos is a good embryo. Yeah. And then you end up with nothing. And that can be very devastating and emotionally overwhelming. So I like to tell them this up front, because I don't like to say like, look, no problem, IVF, we do that, you're going to be pregnant, no worries.
Yeah. Right.
Yeah.
So kind of going off the side of the hormones, and this is one of the reasons why I really wanted to speak to you, because we obviously know as we start to age, our hormones start to decline.
Yeah. Or change.
That's a much better word. They start to change. Yeah. And so when it comes to hormones like estrogen, progesterone, FSH, how does it impact fertility treatment outcomes for women in midlife?
Yeah. So you already named a couple of hormones that are really important for me to know upfront. For example, the FSH, and I like to add one, the AMH, the anti-Müllerian hormone, because those are two markers that give me an idea of your ovarian reserve. And we know that the FSH, follicular stimulating hormone, which is produced by our brain and gives the signal to our ovaries to produce, like to mature the egg, to get the follicle growing, to get to an ovulation. The older we get, the higher our FSH level go. Right. So when I would see in the first lab assessment I would do, the FSH is already very high, that would already tell me, okay, the ovarian responsiveness towards IVF stimulation is probably not really working.
Yeah.
So I think like the magic number for FSH is like 23 or something, right? For the menopause thing.
Yeah.
So if you saw someone, is it 25?
Yeah.
So if you saw someone above 25, is that just...
Yeah. Like unfortunately, then when we look at the other hormone, the AMH, the anti-Müllerian hormone, I can already tell you if the FSH is above 25, the AMH will be 0.05, or some definitely below 0.5. And the AMH is a prognostic marker, also just telling us like how likely it is that you will respond good towards stimulation, or how long do you still have with regular ovulations. So we know, for example, if the AMH is less than 0.5, we probably just get 3 to a maximum of 5 eggs with a stimulation. But when I then would additionally see that the FSH is already above 25, then we have the problem that stimulation won't work at all, because what are we actually giving you in IVF stimulation? We give you FSH, but in much higher doses.
You give someone?
Yeah, that's FSH. Like, obviously we know it has all kinds of name. FSH.
It's stimulating.
Yeah. So you just give more. You just give more. So your body does it with your cycle. A little amount of FSH, follicular stimulating hormone, stimulates your follicle. And we want to stimulate your follicles, like plural. Yeah. So we just give you way more FSH. Right. But if the FSH is already very high in your body itself, you can't push it. Like you can't push the ovarian tissue to say like, then keep on going.
We can't make more eggs.
No. At some point and that's what we have to accept, that nature still plays a role and we are not fertile forever. Yeah. And that is one of the reasons, because our ovaries don't respond any longer. Yeah. So if that would be the outcome of a fertility assessment with my patients, we have to have a long consultation about alternatives. And I think, and I love that about my work here in Cayman, is that I can talk about those alternatives, because where I come from in Germany, donor eggs is not an option, but at least it's something that we could consider here. Donor eggs is nothing somebody chooses in the first place, but it is at least an option.
And that's my next question for you too. How do you even just describe donor eggs in the first place?
So donor eggs means that you could go online into donor banks and choose eggs from a much younger women that are tested, that are making sure they are in good quality and that give you a higher percentage of a possible pregnancy with your partner. But you have to see that it is not your genetics. So if you work together with your partner, as we know, he'll probably be okay. He will be okay. Even if his sperm is bad, we just need one swimmer. Right. So, because they give us always millions with one sample, right? The possibility that we find a good one is quite high. Okay, that you could consider going the donor egg route with your partner's sperm, and you still gonna be pregnant, so and you have the delivery. It's your child.
It still goes inside
but you have
you.
I think it's not easy said like, just go with donor eggs, because you say like, look, I want an offspring of myself. So so that's what I see with my patients. It's a process. It's that they sometimes say like, look, Dr. Lisa, 1 year ago we said like not an option for us. Mm-hmm. But now we did, for example, 2 or 3 rounds of IVF and they failed. Then they're coming back and saying we went back to that thought and we might give it, at least that we look into it. Yeah. And I think it's great to have that, at least have that option.
Yeah. Right? I didn't even know that was an option. I mean, of course I know about sperm donors. Like if you're a single woman, you can get a sperm and have a baby. I didn't know that there were also egg donors.
Yes, I know someone who did it. Do they have donor banks here?
So Barbados Fertility Center is the sister clinic of Cayman Fertility Center, and they have an own donor bank. And we also have some donors already here on island. But when we work together with a donor bank that we know, it's the one in Barbados where they have the majority stored. But you're not it's not mandatory to work with that clinic just because it's our sister clinic. Mm-hmm. Like you can go
anywhere.
Yeah.
And is it? Now, this is really
so many questions.
Can you like choose an eye color and like do you have their history?
Yeah, will get a lot of information about like the family history. Right. Obviously, there's been a lot of blood tests and screening tests before going into being an egg donor, so they make sure that you're a healthy person. But you can definitely see like, does it look similar to you? Like you want something like, look, I have green eyes, I'd like to prefer a donor egg from somebody who also has green eyes. And that's actually
really cool.
Very, very interesting. IVF and hormone stimulation can be very intense. How does this affect a woman's hormonal balance when she's already approaching perimenopause and menopause, as opposed to maybe someone that is younger?
Yeah. First of all, those hormonal stimulation, they are really short term, and they also just have a short term effect. It's temporary. It's not, there's a misconception of like, okay, if I do IVF, will I get earlier into menopause?
Yeah,
because
I heard that.
That's
somebody
wrong.
told me that's true. That's what's going to happen to them because they did IVF.
No, it does not. It does not push you faster into perimenopause or menopause.
So it's just like artificially putting the hormones in, and then they just work their way out of your system.
Yes, yes. But obviously, hormonal stimulation, whether you're young or a little bit like later in life, can have a different effect on each and every one. Like, because for yourself, some are having strong PMS when they're So I have often patients saying like, look, that's what I'm really afraid of. Like when I now put my body through that, like how I'm going to react.
Crazy person?
Yeah. It's difficult to really like foresee and tell them like that's how it's going to work out. For me, I often hear afterwards that they all say like, look, it was way better than I expected. It was like nothing really changed. So I just went through it, and it's obviously a short time that you have to actually do that IVF stimulation, 10 to 12 days. So it's really manageable. And then a couple of days later, it goes back to normal.
It's only 10 to 12 days that you do it.
Usually, yeah, with one IVF stimulation, yes.
Do you have to prepare yourself though before?
Just like what I said, sometimes with supplements that I would recommend, but like in general, IVF stimulation for one round of pushing your ovaries, overrunning your natural cycle is usually just 10 to 12 days of those injections. But what it's like specifically for women, maybe already approaching perimenopause, those hormonal stimulation, of course, can bring a little bit more awareness of some changes in your body that you didn't really recognize before. Because, for example, if we then put you on estrogen tablets, progesterone injections, so we give you hormones that your body might have already started missing, you might feel like, oh, actually, when I was on that, like, something was better. Like, like, for example, hot flushes, night sweats, sleeping disorders, so that they feel somehow, okay, when I add hormones that my body starts missing, that has an effect on me. So that is probably the thing why some just assume that it will put you faster into menopause. I know it's more like, okay, you are more aware of certain symptoms.
Right.
Okay, so there isn't any long-term consequences?
No.
It's out.
It's in and out. Long-term consequences in general about IVF stimulation is more the thing that we at least have to acknowledge, that we are doing procedures or stimulations here where we stimulate your body with high dose of hormones, and we do egg retrievals, and maybe some women do it multiple times, and we don't know for their individual risk what might happen later in life. So we have to tell them, like, okay, we're doing this. This is still a young field in medicine. And sometimes when we get more data, we somehow also get more information and have to say in hindsight, look, that was actually not so good what we did there. It increases the risk for certain cancers, or so that is still something that we have to at least talk about. But you as an individual going through IVF, maybe being 40, 41, not meaning if you would have gone into menopause by the age of 50 that you're now going into it by the age of 45. No, that's not going to happen.
Do you treat anyone 50 or older? Do you do IVF or any type of fertility?
So our age limit at Cayman Fertility Center when it comes to working with donor eggs, what we talked about is 50. That's the age limit here. I know there's countries where there is no age limit. So not saying that then all the hope and possibilities are gone. IVF stimulation is really dependent on the individual.
Right.
And as I said, so that also the individual understands what they are working with. For example, I have women doing IVF stimulation being 44, 45, where you would say from a statistical point of view, not recommended. Mm-hmm. Just for example, a 42-year-old needs an average 100 eggs, so that there's one that leads to a healthy embryo. And that's just, we are not still there like having the baby in your arms. So you still have to go through the pregnancy where you also have some increased risk that we can talk a little bit more about later. But and then going back to, you might just always get 3 to 5 eggs with one stimulation.
Oh, wow.
You can do the math, how long that might take. And that is for a 42-year-old. So in general, we say like after 43, our first recommendation will always be consider donor eggs or adoption or even closure of that topic, because I think that has to be an option too. Mm-hmm. And I tell that my patients too. But if they understand what we are working with what statistics we are working against, then they say like, but I might be different. My body is my body and I'd like to see what's happening. Mm-hmm. Who are we to judge and say like, no, we're not going to do it?
And what about surrogacy?
So surrogacy is not permitted here in Cayman. Okay. It is an option, as we know, in the US or South America. So we help. So, for example, we create the embryos or the eggs, and then those embryos actually also can be shipped all around the world. So, yeah, sometimes we have couples that team up with surrogacy companies somewhere else, and we just help them to create those embryos, and then,
and then they have someone overseas that does it for them. Okay.
Yeah.
Okay.
All right. So much. It's so much that I was just not aware of. I don't have children.
Okay.
I never had children. Yeah. So a lot of this is so new for me and not a conversation I've ever had. Thank you. So we touched on it a little bit, but beyond the physical aspects, what are some of the emotional challenge midlife women, but I guess maybe all women face during fertility treatments, and how would you support them in that?
Yeah. I think that is really an important topic, that we are more just the fertility doctors or the fertility nurse. We are often, I wouldn't say we become friends, but we definitely have to support them throughout the way and maybe even afterwards, or at least guide them. Like, for example, help with a connection to maybe when we need mental health professions to get them in, or also we work closely with acupuncturists here on island to like help them with stress reduction. So yes, the whole journey in general will have a huge emotional impact on you, and also maybe on your
family,
on your partnership, right? So that is definitely something that we always have to acknowledge, and that I often end up my consultations with asking both of them, like, okay, where are we? Like, are you good?
Yeah.
Do you need some help additionally?
Right.
So yeah, I think, and that is what brings me back why I think it's so important to work with a good level of knowledge in the first place, because you know what you're going into.
Yeah.
So you know, okay, what to expect. How does that work with the stimulation? How does it might affect my body? What could be the worst outcome?
Yeah.
So that you can prepare yourself for certain scenarios. And also talk through with your partner at home and say, like, do we want to do that?
Yeah.
Or,
I can imagine it would be quite upsetting and devastating if your dream is to have a family and you're not able to for whatever reason.
Yeah.
So I'm sure it's a lot.
Yeah. Mm-hmm. I mean, and that is why it's at least good that we have the possibility now since 2019 here in Cayman. Earlier they had to fly to Miami. So at least you don't have like that, you have something
for IVF, fertility treatment.
Yeah.
Since 2019.
Yeah. It's still a quite young
new.
clinic.
I didn't know that.
Yeah. So before that, they all had to travel.
Oh, wow.
That makes it even more expensive, and like you have to plan around it. Yeah.
Question. we can take it off if we need to, but does insurance cover?
No, unfortunately not.
It's all out of pocket.
Yeah. Insurance does not cover it. A lot of women don't know about the early decline. Now we say the word decline here in fertility. Like, and I think that is important to know that, fertility, especially for women, declines at a certain age.
Yeah.
So not meaning, okay, after 35 or 36 or 38 or even after 40, as we said in the beginning, your fertile life is over. No, but it gets more difficult and harder.
Yeah.
So as long as you know that, you can take actions, or at least educate yourself and then make a decision what you want to do.
Listen to the podcast.
Yes, exactly.
Yeah.
Okay. How do pre-existing health conditions like thyroid issues, high blood pressure, metabolic changes, how would that influence treatment?
It definitely influences the treatment. So when we do our fertility assessment, I always do also a health assessment in general. And that's what I like here, obviously working with Doctors Hospital and other doctors together, that health becomes like health before fertility. So when I see, okay, we already have a hypertensive disorder or we have a thyroid dysfunction, we deal with that first before going into any kind of fertility treatment, because it has an effect. Like thyroid disorders can lead to irregular cycles or higher miscarriage risk. Hypertensive disorders can get worse when you're then pregnant. So I want to make sure that that person that I have in front of me is in a good health condition. Not saying that if you have high blood pressure or thyroid disorder or insulin resistancy that you're not a suitable candidate for fertility treatment, but yeah, we check that and we make sure that we are perfectly in line with everything.
Yeah. What extra care or monitoring do, say, midlife women need during fertility treatments that like a younger woman might not require?
Yeah. So because we see those changes in the hormone levels through IVF, they might need more blood tests to really make sure, okay, we are on the right track, meaning, okay, are there actually mature eggs that we might retrieve, or are those empty follicles, how we call that? It's now very specific here, but more blood tests. They also might have problems with building up the endometrium when it comes to an embryo transfer. So the endometrium, the tissue that with our cycle builds up, and when we're pregnant, we're not bleeding, but when we're bleeding, when we have our menstrual bleeding, that we withdraw. So they might have problems building up that endometrium because estrogen levels are too low. So we have options. We have estrogen, we have progesterone to make sure that those hormone levels are in the range that we want them to be.
Okay.
How important is a multidisciplinary approach, including nutrition, lifestyle, emotional support, like we talked about, when helping women?
I'm a huge fan of like a holistic approach. So get the nutritions in, get the GPs in, get the mental health providers, acupuncturist, and really also consult your couples to together go on like a healthy lifestyle. Like, maybe you're
because everything helps, right?
Yeah.
Every little thing helps.
But also not too, like, don't put too much pressure on it.
Yeah.
Because sometimes then the couples come back and say like, okay, so we cut down on the caffeine and we cut down on, there's no more alcohol and there's no, of course. But then you also see like they are now stressed. They are now even more stressed than they've been before.
Right.
So, balance is still key, but we definitely help them by asking, okay, how can we additionally help? And
what advice would you give to women in their 40s and 50s who are considering fertility treatments, but they're not sure if it's the right path for them?
Yeah. First of all, go and see a specialist. Talk about it as you see for yourself. So you often get so much information now in social media, like TikTok, Instagram, telling you, it's totally easy, or get an assessment and know your body then afterwards better, because knowledge then is key. And it's more about know more than just be afraid of what might comes out. Like, I get that there's a huge fear behind like, okay, but what if the doctor then tells me it's over? Yeah, but as you heard before now, it's not over. We look and we see, and then we can talk about options, right? And apart from that, as we said, healthy lifestyle, Mediterranean diet. So really see that overall holistic health approaches is there.
And it's good just to have, I guess, that initial consultation and just talk about it.
And to just know where you are. Right? Because what I also, what I often have in my first consultations is that maybe even you need that to find closure. Because maybe you just say like, look, okay, there's maybe sometimes times where I regret something that I did in life or did not. But I know why I did it, and now I'm here. And now I at least know, okay, these would be alternative options, and now I can make a decision or move on.
Yeah.
So
agreed.
Yeah, for sure.
So how can people get a hold of you if they want to come and see you?
Yeah. CaymanIVF.com is the website for the Cayman Fertility Center, or Doctors Hospital has a booking site, because as you heard, like also perimenopausal problems, menopausal topics that they might want to discuss. But yeah, for fertility, it's CaymanIVF.com.
Okay. And how long do you spend with people?
1 hour usually is my first consultation, where I also do an ultrasound to check the uterine cavity, to check the ovaries, to see if there's like any problems already that might make it difficult to conceive, maybe some fibroids or polyps. Check the ovaries for the AFC, the antral follicle count, as a marker for the ovarian reserve. So yeah.
Perfect. Well, good. Well, thank you for coming on.
Thanks for having me.
Thank you so much.
It was my first podcast ever. So yeah.
You did great.
Thank you.
Great.
Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!